still be happy to, yeah. Okay, so I'll just carry on then. Okay. So like I said, we are just trying to go through some stations, and hopefully it would be beneficial for people. And I suppose what we also want to think about is how we can, go through some questions that people may find difficult, and just generally, yeah. So I'm just going to try and move the slides now. I don't know if you can see the slides moving. Okay,
Yeah.
I'll just put it on, yeah, on slideshow. Okay, so as like I said, as we know, we all know what CASC is, or for those who are just writing it for the first time, it's probably, it's the clinical exams for the MRC psych. And 16 stations. We have 4 stations in the 8 stations in the morning, 8 in the afternoon, and it's face to face, isn't it? And the management stations are 4 minutes for reading, and then the other stations are 90 seconds or 1.5 minutes, which is usually history and examination stations. So as we know, CASC is really divided into different parts, and there are just so many things, too many for us to capture. Even for the forensics, it's difficult to capture all in an hour session, or I would even say maybe 40 or 35 minutes session like this. And that's why I said it's just going to be a general overview of things. And I'm hoping if people have questions, and people can contact us afterwards to maybe have more in-depth discussions. But generally, the forensic stations are a bit different. I mean, some people have had the opportunity to work in forensic services, some other people haven't. But for the purpose of the exams, they wouldn't check what postings or specializations you've done. I suppose it's to test everyone's knowledge if they could work at registrar levels. And sometimes people struggle with the forensic station, like I said, just because they haven't had much exposure or experience. I know in our daily roles, we all see patients, take histories, do risk assessments, and sometimes a bit of forensic history. But for the purpose of CASC, isn't it? There are a few things to consider. One of the things is approaching the station generally, people have to understand, whilst we say it's a forensic station, and even in normal practice, sometimes people are a bit biased when maybe someone has done something wrong, say expose themselves indecently, or touch the child, or set a fire, or assaulted people, But for the purpose of CASC, and even in real practice, isn't it? It's about our empathy. It's about being non-judgmental, because we are not the police or the prosecutors or lawyers. We are doctors, and our role is to find out, has someone got a mental illness? Is it the mental illness that has led to them doing what they've done? Or is it just because they've got some personality difficulties? Are they just antisocial? Or, so we are non-judgmental. Or is it because they've done it because they've been under the influence of maybe drugs and alcohol? And like, you will get to see a lot of the forensic stations, not all, because would have issues around maybe confidentiality. I say that because it's not every forensic station that generally you must sort of, because I know I've just having been a CASC tutor for a while, and having practiced with so many different people over the years, sometimes you see people starting every station the same way, say, oh, something like, oh, it's whatever we say is confidential, but because of what has happened, if there's any risk to yourself, I'm going to be telling the police or someone, or I would have to break confidentiality. I suppose you have to be logical about it. It's not every station that will apply to. So whilst we say consider confidentiality, we should also be mindful of, because sometimes it just comes across as very stock phrase or stock answer, sort of, oh, I'm here to see you about this, and I'll tell the police, I will disclose confidentiality. So a case example, if someone has come to you because the police have even brought them, and they've touched a child and things, and they've said, you're going to be speaking to the police about it afterwards, So already that has already sort of set the clinical scenario that this is something that you have to tell people, isn't it? Because they've already asked you in the first place to see this person and give them your findings. So we just have to be careful. So, but where there is room, tell them, yeah, whatever we discuss is confidential. And if there are grounds to break anything, of that confidentiality, I'll do it, So, case example, if say someone has a history of maybe has due to morbid jealousy has assaulted the partner or something, obviously you would have to break that confidentiality and tell the victim or whoever it is. Okay. So we should be empathetic, non-judgmental, try to understand from them what's happened, why has this issue occurred. And always we sort of think about when we are looking at forensic stations in CASC, we want to look at the sort of what happened before the incident, isn't it? So that's the antecedent, what happened during the incident, and then, that's behavior, and then what happened after the incident. So, you know, where were they? What was happening? Were they just waking up or were they angry? Were they under the influence of alcohol? What was the actual incident? What did they do? You know, were they injured? Was someone else injured? And then the consequences, okay, what's happened afterwards? Did they just go back to sleep? Did they call the police? Did they do any sexual acts? Do they feel guilty, remorseful, or do they feel, yeah, it's justified, I haven't done anything wrong? So that's the sort of the consequence, and what's the impact on maybe the victims or whoever was involved with that incident. So there is, it's just simple ABC, isn't it? So antecedent behavior, consequences, okay? And then, like I said at the beginning, for those who've just joined us, when there is an incident or in forensic stations, I suppose for you as the psychiatrist, it's about, you know, what has led to this? Is it because the person has got a mental illness, maybe hearing voices saying people are going to stab you, and that's why they've got a knife and have tried to harm them? Is it just because they've used drugs and alcohol and it's sort of intoxication or as a result of that? Or is it in addition to any mental illness? Or is the person just got some personality problems, antisocial personality, or people with borderline personality could be impulsive and sometimes set fires when they are under stress? Or have they experienced past social difficulties or growing up? Have there been difficulties like traumas and things that have made them, act in that way? And then what's the current social situation for that person? So a common case example would be maybe a patient you've seen who they say expose themselves to children, and when you check the mental state and everything, there's probably no exact sort of mental illness. But then when you ask, well, has anything been happening in your life? And they tell you, oh, my wife has just been diagnosed with cancer, or my child has just been diagnosed with cancer, or my child just died or something, and I just didn't know what to do, So those are some of the things, so social circumstances or issues. And also people, older persons, isn't it, dementia, when there's a change in personality, people with LD, ADHD could present in various ways for various reasons. So these are things we want to look at, in forensic stations when there is an incident, or, you want to just check and find out why they may have done what they have done. And I think an important thing we should always remember about forensic stations is that we also want to check who is affected and if there are other potential sort of victims for that incident or for that situation. So, did the person threaten their wife, husband, partner, are their children involved, or is it an assault on the ward where staff were, involved in or were victims of the person's assault? And oftentimes people forget, for even the patient, for themselves, okay, for yourself, were you injured? I mean, I can hear some background noise coming through, so if we don't mind muting our mics, except if we are speaking or something, or when we want to ask questions, just so that we can. Yeah, okay. But yeah, so we want to always find out. And like I said, one of the things sometimes people forget is even for the patients themselves, if they were injured during the incident. So, for example, someone was in a fight with their partner and there was a knife used or something, one of the things that you want to ask is, oh, was the person injured? What about you yourself? Were you injured? So again, that conveys that empathy, and that shows you're not just there being a bit sort of judgmental, saying, well, you must be the perpetrator or something. So you also want to find out, and that comes across really good in the exams when also ask about the person's welfare. Um, so we'll just move on to the next thing, which is when we are assessing, okay, when there is a forensic session, we've seen the patient, we've taken some history. What are some of the things that would help us guide our risk assessment, isn't it? Because risk assessment is quite broad, isn't it? Risk to self, risk to others, drugs, alcohol. But in the context of this CASC station, someone has presented to you because maybe Mr. X has broken into a woman's house because he believes they're in love, or because he believes he or she is putting thoughts into their head or something. So you want to find out, well, what are the issues promoting these risks? So usually it's good to think about what are the static risk factors, isn't it? What are things that we can't really change, isn't it? They've been there before and they are quite established and well known. So those are static things. So for example, if someone has a diagnosis of schizophrenia, that's something that is not going to change, isn't it? So it's a static risk. Someone who's committed an offense in the past, you can't erase people's histories, except I know in some of the movies they erase people's histories, but in reality, you can't change someone's history. And like we know, anyone who's one of the greatest risk factor is a past risk factor of doing that particular thing. So someone who's set a fire before is more likely to set fire. Someone who is assaulted people is more likely to do it in the future. So those are all static, people who use drugs and alcohol, say historically, and maybe still continue to use it again, that's a static risk factor. And then people who have personality problems, like we talked about earlier, someone who's got AUPD, antisocial personality, or some other personality problems. So those things are static, whereas the dynamic risk factors are things that can change with time or current issues in terms of risk. So, for example, someone has got schizophrenia, we know it's not going to change, but when they take their medications and they are well, they would be like any normal person without the illness. But if, for example, they stop taking their mental medications and then their mental health relapses, or there's a breakthrough psychotic symptom, like they start becoming paranoid and things, so that's their sort of dynamic, isn't it? Something that is happening now, and it's, the current state of them. Or someone who says, oh, it's because I'm in a relationship with this person and I strongly believe this is my girlfriend, even though they've never met the person and things. So that's their current mental state. Could it be because they've used drugs and alcohol, like we talked about, poor compliance with medication? So all these things, I suppose you're supposed to incorporate them into the forensic stations when you're doing your risk assessment. So it's always good to have this sort of framework, like, okay, I'm going to check the past, or the static risk factors, and then dynamic risk factors. Do they have access to weapons? Are there ongoing issues around stress, ongoing thoughts of violence? So one of the common situations these days is, the prisoner who is having thoughts to harm other people because they think people are going to harm them. So again, it's still an ongoing thought of violence, isn't it? Or in the station around, say, morbid jealousy, where they think partner is cheating on me, so I'm looking for the person to harm them, or even the partner themselves. So all those things, you should incorporate it into your history during or into your discussion with the patient. Okay. So it's always good to have this framework. I suppose, like I said at the beginning, the forensic stations, I mean, CASC is generally a broad exam, isn't it? We have, from the last time I had, we have over 300 different case scenarios and stations. But we've sort of looked at the different categories of forensic stations that, have come out in the exams through the years, and I'll be happy if people who've maybe, done the exam more recently may have new stations, but we generally have like the sexually related stations, isn't it? So pedophilia, indecent exposure, erotomania stations, issues around morbid jealousy. I mean, we could put it under sexual related or not, but and then more recently, I think there's been a new station around domestic violence and possible sexual abuse, so that's one category of stations, isn't it? And then another one is the ones to do with violence, things around, someone who's in a prisoner who is having thoughts to assault people, or someone who is on the inpatient unit who's assaulted people, either staff or other patients, or partners, or like we talked about the morbid jealousy stations, where maybe they've assaulted their partner, they've been brought to hospital, and they will ask you to maybe take a risk around future risks. So that is one group of sort of forensic stations we come across in the exams. And another group is the fire setting one, which, again, could be a patient with EUPD who, or someone who's had a history of maybe some form of abuse, and they've lit a fire maybe in the accommodation in their hostel, or someone who's got, ADHD, ASD, LD, who set a fire, or just people who have the diagnosis of fire setting, isn't it? So these are sort of the broad categories of forensic stations we come across in CASC. Like I said, I'm happy for, if there are new stations or other things for people to shout out. Or, I mean, Dr. Ahmed is also here with me. He's co-facilitating the group today. So I'm happy for him to stop me at any point to sort of talk about, if there are other things we would want to think about. But I think broadly speaking, this would cover the main categories of forensic stations we'll come across in CASC. So I suppose for the purpose of our time, and we have a limitation to our time today, and we wouldn't be able to go through all the stations broadly, in much detail. But today's is just an overview of some of the things to think about and how to go about it. So I've just taken a few examples, and then I'll be happy for us to go through some of these stations, which are under the general category of categories of stations. So as you can see from the screen, this is a common station that people come across in CASC, isn't it? The sort of pedophile risk assessment station. So this is a classic or a typical station. I mean, some of the details may not be exactly the same, but it's just to give you an idea. So they may tell you, oh, look at, see a patient who is maybe 30 years, 40 years, 45-year-old man who's been brought in by the police. They may have different professions of yours, loosely used IT consultants. So I'm not saying IT consultants are pedophiles or touch children. It's just obviously an example, who was brought by the police, after the neighbor's child had accused them of touching them. So the question would be, speak with them to explore the incident further. Again, it could be different things, find out what has happened, or discuss with Mr. Banks, about the possible problems, or so they will, or sometimes they may even take it further and say, you've been asked to speak with this man, and you will be giving your feedback to the police. Explore, or sometimes it may just be explore his psychosexual history, or any risk history related to sexual risk histories, assessment or risk. So the question can be phrased either way, but this is just an overview. So at this point, I will just pause and ask, how would people approach this station, and what are their thoughts around this station? I'm happy to, Dr. Ahmed, if you want to chip in now, or if anyone else wants to come in. I don't want to be the only one speaking, but yeah, just.
Yeah. Well, thank you very much, Dr. Harry. I was just going to say that this is the typical classical pedophilia station. And I think in the last exam, we had something like this. But the follow-up question was, could you speak with Mr. Banks to determine whether or not whether children around him could be at risk from him following on from this incident? And it would seem to me that this is one of those stations where the ABC type of thing would be very useful. And maybe it will be A, B, C, then F, because again, we'll look at what's likely to happen in future. if things like this happen. So I think, yeah, this is a usual classic type of pedophilia station. And it would be useful to hear what people think about how to go about it. Or, in fact, if anybody wants to try and role play this, maybe it's a useful way to go about it as well. Okay.
Thank you. Yeah, so I'm happy to be Mr. Banks for today. Not really, I'm not Mr. Banks. I have nothing to do with him. But yeah, is anyone willing to give it a go? Just quickly, just
Yeah,
if
if we have somebody who would like to be the yeah, if you are Mr. Yeah, so is there anyone who'd like to be the doctor saying Mr. Banks? You want to give it a shot? On the meeting, there's Dr. Adeniro, Dr. Betsy, Dr. Chukwonso, Dr. David, and many other people. Anyone? Dr. Mohammed.
there's no right or wrong, isn't it? We're all here just to learn. So is anyone willing to just give it a go, just quickly? Or again, I suppose we want to make it as interactive as possible, isn't it? So that people can contribute and also just, yeah, and it's never easy to volunteer for these things, but you know, is anyone willing to have a go? Okay.
Hello.
Hello.
I'm actually taking a walk, if it's okay, if I can just, say what I will do if I were to, be a candidate with this kind of station.
Yeah.
Is that okay? Because I'm not in a place. I'm taking a walk. Can you hear me clearly?
Yeah, we can hear you clearly.
Yes.
So can I just give it a try?
Yeah. Yes, please.
I think Dr. Adeniro is raising their hands as well. Do they want to be the patient, or do you want to say
I'm
something?
happy to be the Mr. Banks,
Okay.
Happy to give it a try. Sorry, I was having issues with my network previously.
Okay. You do the next one then.
Okay.
Okay.
All right, Dr. Mohammed, you have the floor.
Oh, hello, Mr. Bank. My name is Dr. Mohammed. I'm one of the doctors in the clinic today. My understanding is that you've been brought in by a police because an incident happened today, and I was hoping we could have a discussion about this. Is this okay, Mr. Banks?
Yeah, that's okay, doctor. Thank you. I mean, I'm really taken by surprise because what's happened today is really out of context, but I'm happy to speak with you about today and what may have happened.
All right, thank you, Mr. Banks. So I'd just like to take a bit of, history to just see how, best we may help you. Could you please tell me, about this incident which happened today?
Well, so Doctor, what I'll say is, my neighbor's daughter Anna and her younger sister, Jane, would usually come to my house. I mean, they call me Uncle E, because I've known them for about 2 years, and I'm quite good friends with their parents. And usually, the children would come to the house, stay around when the parents are going out or something, and there's never been an issue. And Anna is quite ticklish, and this. Today, what's happened was, as usual, she's come to the house with her sister, and at some point she started tickling me. I was tickling her, and that was all I know. And next thing I know is she said she was going back home and she wasn't happy with how I tickled her. And next thing is the police have knocked on the door to say this has happened. So, and that's why I said I'm really taken by surprise.
Thank you for sharing that with me, Mr. Banks. Just a few more questions to better understand, this. So you did tell me that you've known Anna for quite a while now.
Yes.
Right, and she does, come to your house frequently. So she came today and, just as usual, she was playing with you and tickled you. Do you want to tell me where she tickled you, Mr. Banks?
Oh, just so I mean, usually around my, side, just a bit below my ribs, she just tickled me there, and I also just tickled her back, and she was laughing, and it went on for about 2-3 minutes, and nothing more. I didn't think anything about it, and that was it. Yes.
Okay. And perchance did she tickle you somewhere else?
I mean, doctor, I mean, it's hard to say, I mean, except if you are specific, but usually, like I said, just usual around, the sides and maybe the hands and things like that. But, nothing, I didn't even think anything of it really.
Okay. And this was going on for how long, Mr. Banks?
It was just about 2-3 minutes, I would say. I mean, I think, yeah, no more than that.
And what happened afterwards?
Well, like I said, she just at some point said, oh, she just didn't feel comfortable and she left the house with her sister, and that was it. And that was it. And like I said, the next thing I knew was a knock on the door by the police.
So where was this going on, if you don't mind me asking?
It was just in the living room because they were watching TV in the living room. I was sat there, and that's where it happened.
Okay. And after she left, do you mind sharing what happened?
Well, like I said, there was nothing happening. I was just sat there drinking a cup of tea, and next thing I got the knock on the door, and it was this allegation made against me.
Okay. A bit of a sensitive question, if you don't mind, Mr. Banks. Did you perchance masturbate when she left?
Doctor, no. There's no reason for that. No.
Okay. All right. And is it Anna alone that you're quite close to in the family? Is there anyone else?
No, like I said earlier, it was with her sister, who, usually Jane, who comes with her, and the parents. I'm familiar with the parents. We've been friends for the last 2 years.
Okay. I'd like to ask, more sensitive questions, if that's okay, Mr. Banks, especially around, your sexuality. Is that okay?
Yeah, that's fine, doctor. I'm happy to answer anything.
Are you in a relationship currently, Mr. Banks?
No. I mean, I've been separated or divorced from my wife for the last 4 years, and I'm not in any relationship.
Have you, perchance have had a relationship with someone way younger than you?
Oh, doctor, no. I mean, I'm not that kind of person. I mean, my relationships have all been maybe 3-4 years younger than me, but no.
Okay. Have you ever, fantasized, about children in a sexual manner?
Doctor, no, nothing of such, no.
Okay. And has there been any incidents in the past, involving the police? Any similar incidents in the past?
Well, doctor, I mean, this was a misunderstanding that was about 10 years ago. I would say I was somewhere in the swimming pool, and a teenage girl sort of said I touched her underwater. But again, there was no evidence for that. The police checked, the CCTV and things, and nothing came out of it really, but nothing of such.
Okay, so nothing came out of that incident. All right. Do you watch pornography, Mr. Banks?
Oh, doctor, no, I have no use for pornography, no.
Okay. All right. Thank you so much for talking to me, Mr. Banks. I know it's a very difficult discussion to have, considering the sensitive nature. From what you've told me, this incident, happened in your living room, and you're quite close to Anna, and this is not the first time she would come over to play with you. She did touch you, tickle you in a usual way, and you did tickle her back, but nothing, unusual. And afterwards, the police came in. You after the incident, that you did not masturbate or have an erection, and the police did come after the incident to bring you into hospital. What I would like to do is to, I think I'm just blabbing.
All right. No, but well done. I will, I would say well done. I will just ask Dr. Ahmed to make some comments, but well done.
I didn't even know how to conclude it.
Yeah, again,
Yeah,
that's
but I think in a sense, in the direction in which you
And
are
it
going,
wasn't structured. I felt it wasn't. I didn't have a structure. I was following. I knew some of the questions to ask, but I think it wasn't structured. It didn't appear like I was following a structure.
yeah,
So
I
yeah,
think in
I
a
would
sense,
appreciate comment. Yeah.
yeah, what you were doing, what you've tried to do is exactly what one would expect anyone to do, and probably just conclude along the directions in which you were concluding. And I
Okay.
would say that maybe sometimes the guys here, as you know, they like to skirt around the issues a little bit before they hit the nail on the head. So that might be something that one might want to try and work on. But generally, that's the structure. We look at what happened. And then also, the psychosexual history has got a few more bits in it. In terms of, how he felt around his sort of his own sexual history, what his relationships have been like. If he has friends that consume or that use pornography, and also the exact details of the incident. I know it's not very comfortable to ask about such details, but you mentioned whether or not you reported that he did not have any erection, but you actually could not muster
Yeah.
the
The
will
courage to ask. Well,
the courage to ask.
I remembered, but yeah.
Yeah. So
Yeah, that's correct.
yeah, we just have to become, in quotes, immodest, so to speak, when we're asking these questions.
Yeah.
I think. Yeah. And then also, it might be important to ask about what sort of work this gentleman does, if it's the tax that allows him to have access to children. Then people
Children.
also, yes, like to ask about what does he feel? How does he feel about what has happened? And if now or anybody else comes to him in future, what is he likely to do in terms of tickling around sensitive areas? Also, maybe you will want to ask about okay, yeah. So I think basically those are some of the things I can remember about what you've asked. And it's important also, Dr. Mohammed, about how does Mr. Banks, what does Mr. Bank think about how Anna is feeling right now? How do you think she's feeling, to see whether or not he feels any sense of remorse, And then can I ask you, do you think this lady kids are safe around this gentleman, Mr. Banks? I mean, based on what you've asked him now, would you say that children are safe around him?
Okay, based on my assessment, yeah, I would think so. Yeah, because he's not had any similar history or any convictions around that is of a sexual nature in the past. And well, from what is described, it seems just like an innocent play with a child. That's what I think.
Okay, maybe Dr. Harry agrees or disagrees. I'm not sure.
I think, again, so this is really an interesting case, an example of why this station, the people struggle with this station, because just to sort of, well done to you, very bold for doing this, and taking a walk in the park and still able to bring your thoughts together. I can't do that. I would have fallen into a pit by now. But one of the pitfalls is these stations, mostly the people would come across as innocent. They will downplay their roles. They will downplay their offense history. They will portray themselves as good people, that this is just a misunderstanding. And that's why they've brought out these stations, because they know people will then not dig deep enough to find out the true things. So like, maybe you could ask, where did you touch her really? This lady, she touched you on the side. Where did you touch her? And then it's happened before, isn't it? Where they've accused him, but he just downplayed it out. There was no evidence and this, So again, it's beginning to tell us the kind of person this man is, isn't it? So that's one of the common pitfalls. And I would say, like Dr. Ahmed said earlier, the psychosexual history is quite important, So these are some little things, but usually the patients will always downplay their role, always come across
Yeah.
as good people, and people then fall into that, oh, I'm non-judgmental, this is a good man, I can let him have access to children. And also ask, are there other children living in the house? Do other children come around? Because if one neighbor is trusting him, we don't know how many neighbors are trusting this man with children, isn't it? So
Children.
if he has, even does he have his own kids in the house? Does he have kids? Does he have access? Okay. Dr. Adeniran is raising up his hand, so I suppose he wants to say something. But well done, Dr. Mohammed. That's why we want people to come to sessions like this and, just get to see some of the little things that make people struggle. I would say this I know it's been recorded, but historically females tend to fail this station more because, again, of that sense of they don't want to ask those questions that feel a bit uncomfortable, so that's what the statistics from, people who are, have said, that females are less likely to, or amongst those who don't pass the stations, females form a higher proportion, and these are the reasons why. Okay, so like Dr. Ahmed said in the first instance, people may have to be a bit immodest in quotes about and ask those sexual histories. All right, Dr. Deniran, sorry, I know our time is fast going, and like I said, we can't cover the whole forensic stations in this time frame, but
Thank you
yeah,
so much. Thank you.
no, thank you to you. Dr. Deniran, you've
Oh,
raised your
sorry,
hand
that was from before.
Oh, from before, okay.
from before. Okay. Sometimes people have online catatonia, where you just take one position and it's hard to come down again. But thanks for letting us know that lorazepam has reduced catatonia. Okay, let's go to the. Okay, but I think that was a very good try, and yeah, let's look at the next station then. I'm just trying to pick stations from, various, like we said, different categories, like we mentioned earlier. So this is also another station that comes out quite often, like Dr. Ahmed mentioned earlier. Sometimes they add extra bits to the stations, but this is just a general overview of what a station like this may look like, So you've been asked to see this gentleman who, again, he threatened his girlfriend with a knife because he believes she's been cheating on him or putting thoughts in his head. It could be either way. Then they will say take a history to find out the current issues and the future risks of or any future risks. So again, Dr. Deniro, I know you've been eager to have a go, isn't it? So perhaps it's your time to. I'm happy to be Andrew Clark again. If or Dr. Ahmed, do you want to be Andrew, or shall I just carry on and be
I'm
and be?
happy to be Andrew. Andrew does look like me.
All right, so I'll give you the floor then. All right, so
Just note that we have 15 minutes left.
15 minutes. Okay, so
Okay.
we will.
Yeah.
Okay.
Can I start?
Yes, please.
Yes, please.
Hello, is this Mr. Clark?
Yeah. Hi.
Hello, I'm Dr. Adedoyi, one of the doctors in the mental health unit today. I have been aware that there's been some difficulties at home and you were brought into the hospital.
Yeah.
Yeah, could you tell me what happened?
Oh well, it was just a little tiff I had with my wife this morning, my girlfriend, when I think I'm just here because they were afraid of the knife, because I had a knife, and that's it.
Right. So thank you for telling me that. But could you tell me what led to you because I've read in your note that you threatened your girlfriend with a knife.
Yeah, actually, she made me threaten her because she's a nurse and she's been having this affair with one of the doctors at her workplace, and I've warned her against it, but to no avail. So I just wanted to make a point this morning that if she does it again, just to scare her, basically.
Right. You said she's been having an affair with her boss. Could you tell me more about that? How you found out?
Yeah, so there's a doctor at work, Dr. James. They claim to be on the same team. They're always talking, and I think they've been having some sexual encounters, which is why I think my wife is no longer interested in my girlfriend is no longer interested in being with me in bed, and I find it very frustrating. So, yeah.
Right. You said they've been having some sexual encounter.
Yeah.
How did you come to know about this?
Well, when people have sexual encounters, they call themselves regularly, don't they? They have each other's phone numbers. I just know anyway.
Mm-hmm. Right. Could there be other reasons? I mean, you said she is a nurse, and this person you're suspicious is a
It's a
doctor.
Yeah.
Could it just be that they've got work relationship to discuss?
No. It's more than that. Yeah, it's more than
Right.
that.
Right. So you're certain that this is what had happened.
100%.
Okay. And about earlier on, you said you tried to threaten her with a knife. Was there any other thought on your mind, possibly to use this knife on her?
I love my wife. I don't plan to use the knife, but I could make a point, with the knife, even if it's just a tiny scratch, just a scratch on the finger, to make her realize I was being very serious.
Oh, okay. Okay. That sounds okay. Is there any other thought that's been bothering you that you'd like to share with me?
I'm just bothered constantly about what they are doing. You see, at the moment, she's gone to the hospital. She's gone to work. The guy, I'm sure, is also at work. Probably they are doing things behind my back.
So probably they're doing things behind your back. Is there anything you want to do to possibly understand more of this?
No, I want. If you leave me, I just want to go to the hospital to have a chat with the guy, the doctor.
Okay. And when you threatened her with a knife, what then happened afterwards?
Well, she shouted, and the neighbors came around, and I don't know who rang the police, and here we are.
Okay. And how does this make you feel at this point?
Well, I feel she must have learned her lesson now. That's the feeling I have.
Can I ask, Mr. Andrew, this kind of thing happened in the past?
Yeah, it has, yes.
Do you want to tell me more about it?
Okay, so this was 4 years ago when I had a girlfriend. It was in Scotland at the time, and she was also having an affair. I don't know what's wrong with women, they just like to have these affairs, and I threatened her. Actually, when I was threatening her at that time with the knife, she actually wounded herself with the knife. I was holding it, but she wanted to take the knife from me, and then she cut herself on the hand.
Oh.
So she needed a few stitches at the time. And the police came, and well, they couldn't find anything. They didn't say I did it. So
Right. So you were not charged?
No. They just wanted me to go to hospital at the time.
All right. Okay. I need to ask a few more questions about you. That's okay.
Yeah.
All right. Apart from your wife, is there any other person at home? Your
No.
girlfriend, sorry.
No,
Nobody.
Just
yourself. And what do you do for work?
I'm a builder.
You're a builder. All right. Do you have any other relationship apart from your wife, your girlfriend?
No.
Not at all. Have you had any difficulties around your mental health in the past?
In the past, yes.
And are you currently on any treatment?
No, it's those treatments, they deaden your libido, they deaden your manhood. So I don't take them. Those olanzapine and things to give me before. No, I don't like them.
You don't like them. So have you been offered before?
Yeah, I have, yes.
So are you still taking it?
No.
Not at all. Right.
No.
Mr. Clark, do you have any
Yeah.
Any.
All right. I don't know. I think just for the sake of time, I know we've got just 9 minutes left. It's but well done, Dr. Adeniran. I mean, I suppose it was more to give people an opportunity to begin to see what the questions are like, how to have a go at it. And I think you had a structure in terms of what you wanted to do and how you wanted to do it, I suppose. So that's really good. sort of the ABC, antecedent behavior, consequence, and then past risk, present risk, mental state, so it's good. I mean, I don't want to go a bit too much into details just because of the time scale, but one thing I could see clearly is you knew what you wanted to ask, and you had a bit of a structure of how you wanted to ask it, but we would see clearly that in these stations, people need more structure. It's good to make it very structured. What happened? Where was it? Were they under the influence of drugs, alcohol at the time? Is it because of some mental illness? He was alluding to some mental illness. We could just check a bit more. Of us, is there any evidence for all of this happening, or is it just a delusion this man is having? It was difficult to pick some of those things. Has he ever done this kind of thing before? Very good. You asked about that access to weapons. Has he ever been in prison? Those little things we could look at, previous violence, convictions. Obviously, he's told you he doesn't believe he's unwell or something in terms of drugs and things. So there should be, again, one of the things we'll think about is in the exams, time may not really be our friend. So if we're not structured, we'll be going to and fro, and before you know, the time is over. So I suppose these are some of the little things we want to bring out in some of these stations, and then to help people understand good structure, practice, timekeeping are very important. So I would, just because of our time, I'm not able to give so much details, access to weapons, and things like that. I don't know, Dr. Ahmed, is there anything you want to add before I move on? But well done. That was a very good, thank you for volunteering, Dr. Adedoyin, and for the try. Dr. Ahmed?
Yeah, I was just going to thank Dr. Adedoyin for a very good attempt. And I think one thing I noticed, though, is something I was also guilty of, is mistaking people's identities. So it's the wife, not the girlfriend, or his name is Adeniran, not Adedoyin, that sort of thing. We think it really doesn't matter, but actually, if you make that mistake twice in an exam, the examiner might not take too kindly to it. So we've got to be a bit mindful of that. But other than that, I think what Dr. Harry has said about it all is gold. Structure, more practice, and it's almost as though you're automated almost in the way you think. And also, sometimes in the exam they drop a few hints in some stations. I'm not sure whether I did it well enough, but when I was saying, oh, they just took me to some hospital, or they give me some, it was a hint that there was something else happening there. Somebody could say, oh, I've been taking some medications, and yeah, I don't want to take those meds again. Then you keep asking him questions. Then the guy says, oh, doctor, the lithium I'm taking, does it have any sexual side effects, for example? Then it means that guy probably has got sexual side effects of certain medications. So you want to ask him about what other medication he's taking, because lithium doesn't affect his sexual performance. The point is a bit tangential, but what I'm trying to say is they drop hints, so you've got to be a bit sensitive to it.
And I think for me, once someone, I mean, again, just speaking to that, he's told me, oh, he was being given olanzapine or something. So you need to ask, oh, have you got a diagnosis really? Just something that, so clearly the examiner has seen, you've picked on, and he'll tell, oh yeah, of course, they said I had schizophrenia, I don't believe them, or, something like that. So clearly this guy has got a diagnosed mental illness, so those are little things. They sometimes drop those clues and expect us to follow up on those lines of questioning, but I think that's really a good attempt. And obviously time is not our friend. We started a bit later because we're waiting for people to join, but again, one other station would be something around, we wouldn't have the time to go through all of them, prison assault, someone, maybe they will tell you the nurse has told you to speak about this patient because he assaulted someone in the past and he's in prison now, and he's telling you he's hearing voices to harm people. They don't know if he's used drugs. Then they'll speak with the nurse, to talk about this person, and because the nurses are like, well, this guy should go back to prison. There's nothing wrong with them. We have too much work to do. So they want you to take a history. around that and find out what's happening and put some management plans. Okay. And also the fire setting station, again, it's one of the sort of broader topics that people come with, again, we need to follow the ABC. Where were they? What was happening? What led to them setting a fire? Were they under the influence of any substance, alcohol, drugs? Was anyone injured? Are they regretful? They themselves, were they injured? What was their reason for setting the fire? And if they said they were watching stuff on TV, maybe related to sexual abuse, you need to empathetically ask them, oh, is this something that, has happened to you, someone you know, or anything like that? Did they bring back any memories? So very sensitively and empathetically ask, to find out why. Then do they, are they remorseful for what has happened, the fire setting? Have they done it in the past? Will they do it in the future? Also, if they hint at, say, oh, it was my foster parents who sexually abused me, for example, again, it's a hint. Okay, well, if that's a foster parent who sexually abused you, are you still in touch with them? Do you know if they have access to kids? And then for the patient themselves, so whenever you're stressed, is this how you respond? Have you been under the mental health services? Perhaps we need to think about ways of helping you cope, with stress rather than setting fires, if you're not under a service or something. So these are just general, it's just a general overview. I'm really sorry, our time is not enough, but just a few quick lines, things to remember, especially when there are children involved, just safeguarding, like we said now in the fire setting. If, for example, that person has foster parents who are in touch with children, or like the first station we did where is this person in contact with other children, straight away we need to pick up on the safeguarding issues. There's always risk assessment in almost all the stations, but I think the forensic stations are quite different, isn't it? Because the key focus is the risks. Also, if they tell you, oh, I use drugs, you want to ask 2, 3, 4 drugs, alcohol as well, and vice versa. And I think there's a new station, I think, that came out in the last exam, which had to do with domestic violence and possibility of sexual abuse, So again, people need to think about it. So I think at this point, I'll just stop my presentation because we haven't got the time. And I suppose we just want to think about, for us, we want to keep doing these sessions once every month, isn't it, Victoria, from CASC? But today was just a bit of quick introduction and taster. So Vicky, I'll hand over to you. But it was just a taster and just to generally explore a few things. Vicky?
Okay. Thank you very much, Dr. Haruna. I think that was really helpful and enlightening to people. Just to say that, like we said, this is going to be a monthly session. It's free. So invite people that will be taking the CASC exam. The next time that we're going to have will be the last Saturday of every month. So the next time we're going to have psychotherapy stations. So we'll have an overview of that. So please try and make it a date. So this is being organized by CASC. We're a group that try to help people on their path to success in the CASC exam. And we provide one-to-one tutoring. So you can contact us if you are interested. I'll put our email address in the chat if you want to contact us after this. We provide mock exams. We provide small group course as well. And I'm just gonna ask Dr. Ahmed to say a little bit because he's been someone that we've worked with at CASC. So if you can tell us a little bit about your experience.
Right. So as a matter of fact, I can say that, and it's not because I'm here, but also because it's true. I found my trainings in the past, my sessions, my lessons with CASC incredibly useful, especially at that time because I didn't really like being in another open forum for personal reasons. I found it very useful. I found the tutors very knowledgeable, and I could almost remember some of the things. I mean, I could almost hear them teach me, tell me, point me in the right direction whilst in the exam. So, for example, you have a station where a similar situations that has been highlighted before, came up in the exam, and I could remember the day the tutors were saying, oh, if this happens, it's almost like a prescient sort of experience. This is what's going to happen in the exam. And when it happens, this is what you say. And when such situations arise in exams, it gives you a lot of confidence that, yeah, this is a response, the appropriate response. And that helps you to carry on to the next session. So in summary, I have found the experience very, very useful. And that's why I'm a part of this now. So I would recommend that, as a matter of fact, it is very good to be part of this CASC. You have nothing to lose based on my own experience. I did the mock the last time, and the mock is almost predictive of what's going to happen in the exam. So if prior to the exam you're able to sort of study hard, do well in the mocks, then there's a very high chance that when you get to the exam, you will do well. It doesn't mean that one is not going to do well if you don't do well in the mocks, but I mean, doing well in the mocks certainly predictive of how well you're going to do. And I can remember Dr. Harry sending me stuff on frontal lobe assessment and all that kind of stuff that I really never liked. And it was those stuff like, okay, well, he sent it, let me just, go through it once and for all. And they were really very useful. So I would say, when you look at what's on the offer, it's worth your time, it's worth the efforts. It's worth the money for me. It was worth the money. Thank you very much.
Thank you, Dr. Ahmed. I mean, it's very kind of you to say, but you've become part of us now. But yeah, I would say, yeah, guys, thanks for joining us. And some of you I know personally, isn't it? I've met in passing on WhatsApp or some places, so it's good to see some of your faces today. But yeah, and let's hope you join us next time. And like Vicky and Dr. Ahmed have said, if you want to join us for the one-to-one practice sessions, the mocks and things, it's all things we'll be doing at reasonable rates compared to other people. But yeah, it's our hope that people pass the exams. I think that's the most important thing, whether they attend our courses or they attend the free ones. It's for us, people passing the exam is the most important. So thank you for joining us today, Vicky. I'll hand over to you to round up because I don't know how to summarize things. Yeah.
Just thank you everyone for coming today, and we wish you all the best as you prepare for your exam. Yeah, and see you next time. Okay. All right. Thank you.
Thank you. Bye.
Thank you.
Bye-bye.
Thanks, everyone.
Thank you.
Thanks, Vicky.
Okay. Harry, yeah, we'll catch up tomorrow in the group. I'm just waiting for to tell me things because Adora has come back and she's okay with it. So as soon as Julian approves it, yeah, he's just approved it just now. Add him to the CASC group. Are you free tomorrow at 3 p.m.?
Yeah, I'm free tomorrow. Yeah.
Because I might need to move the meeting early because I need to even catch up with you, Harry, and I have some things on. But yeah, I'll put down the group. Thank you so much.
All right, so all right, Chief Vicky. All right, thank you very much. Yeah, thanks.